I'm Dick Ferber. I started or co-started, but then ran the Center for Pediatric Sleep Disorders at Boston Children's Hospital. We started it in 1978. Back then, nobody went to medical school and said, I'm going to go into sleep. Everybody kind of got into it in some strange way or another. For me, I was working for Peter Wolf, a research psychiatrist who was very interested in rhythms. And we were studying crying rhythms, sucking rhythms, and he actually also studied sleep rhythms in babies, would watch them from the moment they were born, and just by watching them, not with polygraphs, just eyes and pencil, would see them go through the different stages, and he could document it, and it was pretty close to what it ended up with. I was with him for about 4 years, and we got to do lots of different issues around rhythms and sleep. And what a lot of people in the academy don't know is even back then, there was a very rich literature on pediatric sleep. Not so much clinically, but there were, especially out of Europe, there was in the United States, there was Arthur Parmalee at UCLA, and there was Tom Anders, who was a little older than me and had started doing some important stuff here. But a lot of it came out of Europe. There was Hans Sprechtel out of Holland, who had hundreds of papers on sleep. Way back then, he did things like 24-hour power spectra of EEGs, seeing the rise and fall, breaking kids into states, looking at spindle frequency in hypothyroid children. Very good basic research that, like I say that name today and most people have never heard of him. There were people out of, especially women, a group of women out of France, Czechoslovakia, who had done very nice research on various aspects of sleep in children. So that gave me a great interest in that. And around that time, sleep centers were starting to open. So like Stanford, Montefiore, and I got more and more interested. But after about 4 years, Dr. Wolf said, do I want to stay on as a fellow for the next year? And I said, well, I really should move on. And he said, and this is one of those great moments, he said, well, if you could do anything, what would you do? And I said, well, I'd love to meet up with someone who has a little more clout in the hospital than I did. I was a fellow, an instructor, and I said, I'd like to start a sleep disorders program for children. And he said, that's interesting. And really within the next day or two people came over and talked to him. One was Cesare Lombroso, who was the head of the neurophysiology department and ran the EEGs, and was talking to him about the fact that seizures were so common in sleep, but they didn't do any overnight sleep studies, and he was interested in doing that. And the acting head of psychiatry came over, Dr. Belfer, Myron Belfer, said, talked to him and said, you know, we see so many sleep problems in our clinical population. We were wondering if we should set up a sleep center of some sort. And he put me together with each of these people. And Dr. Lombroso, even though I didn't have a background in EEG or even neurology, took me on to set up their sleep unit. And with Dr. Belfer, we set up a sleep program in psychiatry. So they were separate initially. And in the clinic part, we initially had no idea what to do. The way we got our first referrals was we listed our clinic with the hospital switchboard. The operator, they had a list of clinics. If somebody called up and said, I have a sleep problem, they'd look down, they'd say, oh, Sleep Disorders Center. It took me a long time till I could actually get referrals from within the hospital because they didn't take it very seriously. And everybody who came in had a complete psychiatric interview, not complete, but a number of psychology testing. And then I met with them. And it didn't take that long before we saw that the patients that we were seeing clinically did not need all of that psychiatric and psychological workup. And we kind of let that fall by the wayside. And I ended up doing most of that, and that continued. In the seizure unit, we did set up and did a sleep study. I think initially maybe it was one study every 3 weeks. We had no lab to set up for an overnight study. We set up in the corner of the sort of back, it was a repair area and a place behind a sliding door and a cot, and we set that up. We had no video. We had, of course, the grass polygraphs that everybody had back then. And we would do it, and I would peek around the corner to see what was happening. And when you did a study back then, it wasn't recorded on computers. It was all paper. So it was paper about a yard high, and when we were through, it would be about a mile long. And we would go through and score it. And Giuseppe Erba was the person I worked with in the clinic there, who worked with me on getting used to looking at EEGs and recognizing it and scoring it. And then based on the paper speed and how many pages in each state, we would calculate how many minutes in each state. And then we had no computer to draw the graph. I'd get out a piece of graph paper and draw out the somnogram. And that's how it was initially done. Kind of hard to believe. When I started in 1978, I said, I really should go somewhere where I can get a little more training. And there wasn't anything. I mean, there were no fellowships, programs. So I called on the East Coast, the biggest center that existed then, and was quite big for the time, forever actually, was the Sleep-Wake Disorder Unit at Montefiore. And I called Elliot Weitzman, who was head of the unit and a great pioneer in sleep and circadian rhythms. And I told him I wanted to start a sleep center. And he said, and I wanted to get some training. And I said, I was wondering if I could come down there and stay there for a month and learn what I could. And Elliot, I will thank him for this forever. He said, no. He said, you can't do that. There's too much to learn. If you want to come, you're going to have to come for at least 2 months. Got a little more complicated in terms of what I was doing at the time, but I worked that out, and I went down there for 2 months. And he got me and they had the residents on-call rooms were up on the top floor of the building where the sleep-wake disorder unit. So I had a little cubicle that I lived in up there for 2 months. And I would come down during the day and sit in on interviews and the scoring. Peter McGregor was their chief technologist, who later I think worked for Grass, and Peter with his Scottish accent taught me really how to score records. And He did it standing up. And until we moved to computers some years later, I continued to do it standing up. When I took the boards, I think the first or second year was offered, everyone's in the room at the table going through the pages. I stood up because that's how I was used to doing it. But I learned an incredible amount. I met incredibly great people there who are still my friends today, who stayed in sleep. Not all of them are still alive. Charlie Pollack used to spend incredible amounts of time with me, one-on-one afterwards. Going in with Elliot Weitzman to listen to his interview really had an impact on how I did things. Elliot was very interested in the rhythms and the circadian rhythms, and the delayed sleep phase was, I think he was the one who called that. And I'd go in, and even though he was head of neurology and head of the sleep, he never rushed anything. Anyone who's been at one of his lectures would know that. And he would take the interview of everybody around the clock. I don't remember where he started, but what time is dinner? What time did you go to bed? When did you turn the lights off? When did you fall asleep? What happened all the way through the night, and then again all the way through the day. And I continued to do that my entire career. I taught that to everyone that I was fortunate enough to work with and to teach. That I found that by the time I got around the clock with that history, I usually knew what the problem was. I could pick out from that habits. I could pick out from that certainly the schedule, which I became to see more and more and more critical in children's sleep. The other thing that helped me a great deal in the beginning was the beginning of the Sleep Academy. It wasn't Academy way back then. There was the precursor of the Sleep Research Society, the APSS, and they had big meetings, research-based, single track. And I think, well, I know the first one I went to was at Cape Cod. I can't remember if it was 78, 79, somewhere in there. But the first meeting of the precursor of the society, we went to, I was in a little room at the airport in Chicago. And there may have been 15 people there. And I remember Dr. Belfer and I sat in the back, and there was Dement and Weitzman and Chakravarti and Helmut Schmidt and so on, and Bill Orr. And they were all yelling at each other about things. There was never sitting down quietly, here's what we were going to do. They were yelling, but not in a way that was crazy. I was just incredibly impressed with these people. They were all very smart, making sense, good arguments. Nobody was just sitting down and saying, okay, whatever you want to do. And they fought this thing through. And I continued to go to those early meetings, every meeting actually, and the SRS all the way through its development. Not too long after it had developed, Helmut asked me to join the board as treasurer. This was the treasurer of the precursor of the academy, ASDA, ASDC. I really forget which came first and last and it changed almost every year. But I got to know all these people very well, got to be on the early exam committee, which was, again, without computers, we had to produce the same copy of a sleep study on many, many reams of paper, which was very difficult to do. Helmut did much of that in Ohio, and we would go through and make our questions and set it up, and that's how it was done. It was hard to believe. All of that stuff is hard to believe. In fact, going back to my graph, and compared to what we have now, we got an Apple II computer in the lab. And I said, well, maybe we can use this. And I had to learn Pascal, which was a program. And I wrote a program to feed in the page number and the state. And you'd also tell it what paper speed it was and the time, and go through, and you would just type in page number, like page 1, stage 0, page 25, 1. And you would do that, and then the goal was it would then calculate all the numbers that we were doing by hand, and it would draw the graph. And it was, even that was so primitive, just to get it to draw the graph, you had to like tell it which pixels to go to on the screen. And then to get it to print out on this dot matrix printer was similarly complicated. But when we got the thing working, it just saved so much time. And we used that in the subsequent version of that for a long time before we finally moved to the more advanced machines that gradually came out. Well, the literature did refer to, was all research. There was almost no clinical work, basically none. Certainly nothing formal. And when we started our center in 1978, it was the only center anywhere dealing with children. Europe, United States, there was no place else. So we had no clinical resource like that to help us go. And it was kind of trial by error. I still remember my first, well, before I tell you about my first patient, there were a few things. I remember there was, I wish I could find it again. There was, in one of the British journals, they had this journal with these little small 1 paragraph, 2 paragraph items in there. And there was this item about somebody describing the sleep problems, some of the sleep issues in children, and he describes some of these things as just habits. And that really struck me, that the idea that having to be rocked to sleep or your back rubbed or using a pacifier wasn't a necessary part of sleep. It was just a habit. And when you didn't do it, the reason they had trouble sleeping was they were used to a different way. And that article, that paragraph, made it sound like you can change these habits pretty quickly. And we did that starting with our first patient. They called up, got the switchboard, put them in our center. We did the full psychiatry, psychology, and me. And it was what turned out to be a kind of classic problem of the kind that we saw over and over again over many years. In this case, there was nothing medically wrong with the child. It was, I forget, probably about 2 years old, something like that. There was nothing medically wrong with the child, certainly nothing psychologically wrong with the child, but they were, I think, rubbing the back or patting the back, and they would have to keep doing that repeatedly throughout the night, every time the child woke. And I also had learned, just from the sleep even of older people, that although sleep may seem continuous at night, that it is broken by little wakings. And I could certainly see that from the beginning with the sleep studies. And the wakings, if they were short enough, you didn't remember them. And just like if periods of sleep are short enough, you don't think you fell asleep. So people didn't realize that their child was waking naturally, then finding their back wasn't being rubbed and needed that. And so we told her basically to stop that. And we said, well, maybe check them in a few minutes and check them a little longer, but don't rub their back. And they left, and I was really, really scared because I figured they were going to come back in, I forget, 2 weeks and tell us it was a disaster. We've just had 2 weeks of crying. Then I was thinking, what are we going to do? What are we going to do? And they came in, and the mother started to ask me some different kinds of questions, but didn't talk about the sleep at all. And I finally said, well, what's happening with the sleep? And she said, oh, well, we did what you said, and after 2 nights, she was sleeping perfectly. And I always wonder what would have happened if that first patient hadn't gone so perfectly. But it turned out that was the kind of problem and solution that we found. Something very rare in pediatrics, in medicine in general, and not just make a symptom better, but actually cure a problem, and to do so without medication. Not too many things that were falling into that area. And I found that it was really terrific from the side of a physician from that point. People would come in, they've been to their doctor, they've been to another doctor, they've talked to all their friends, they've gotten all this advice, nothing was working, they'd really given up any chance. And the thought of just giving them some instructions, and then within a few days to a week, the child is sleeping better. You not only give the child sleep, but you give the sleep back to the parents. And this was amazing. And people would come in and just so full of gratitude. I always felt that, if you bring your child in and they have a tumor, let's say, and they need to have it taken out, and it's taken out and the child's fine, maybe not a tumor, but something that any pediatrician or you could have gone to could have solved that, say ear infection. They're grateful, but it's not like we finally stumbled on the one person who could solve that. And that was the feeling they came back to me. They felt like nobody else in the world could solve that, and we solved it so quickly. Well, the idea of graduated extinction came from looking at the idea of thinking of it as a habit and thinking of it as how quick children learn, and one habit can learn another. But although for whatever reason, not one that I'm all that happy about, the idea of that being associated with what we did, and that was our, quote, approach, was something that we didn't practice, and I never believed in. I strongly found early on that there were a number of reasons that children didn't sleep well. That habits, back rubbing, rocking, pacifier, was one of them. But there were many others, and they had to or should be treated differently. Schedule was probably one of the most important because it was so frequently missed by anybody else. They didn't know how to take that history and didn't know how to interpret it. So we would see, for example, and they're complaining that their child isn't sleeping. And then when you take the history, you would find out that they were putting them to bed at 7 and getting up the next day at 7 or 8, and they were taking or scheduled for 2 3-hour naps. And that was way beyond the amount of sleep a child could get. And just shortening the schedule or making it appropriate, cutting out the nap, would cure the problem in one night. There was no crying involved, no gradual extinction. And that was always probably my favorite, especially if it was, say, a 10-year-old who is being put to bed at 7, getting up at 7, can't sleep 12 hours, and was causing a lot of problems, especially early on. Of course, early on, when they were putting them to bed, I later learned was the so-called zone where not only can't you fall asleep, but you're more awake then than at any time of the day. That was a great piece of information to learn, and I could explain that, and they were putting kids to bed when they were least able to fall asleep. And then, of course, they might say, well, so much trouble last night, we're putting you to bed earlier tonight and just go. And so we would say, okay, what time does he actually fall asleep? Well, he falls asleep at 9. What's the latest he falls asleep? Well, he's always asleep by 9:30. Okay. What time does he wake up in the morning on his own? Well, he's been waking up on his own at 6:30. All right. Let's start with a bedtime of 9:30. And this was great because I would get these looks from the family at the same time. This look of kind of disbelief, am I crazy, from the parents. And the youngster would be sitting there and this little grin would come up on their face. They couldn't believe it. They were expecting the worst. And sometimes it would take a little convincing, but they would go home. We say, we'll start with that and we'll adjust from there. And they would go home, keep the youngster up till 9:30. He'd go to bed and go right to sleep. Get him up at 6:30 for starters. And then we could see if we needed, if he always had to be wakened, we could expand it and so on. And we made it match. This goes back to Elliot Weitzman because, like I said, he taught that's how you have to take the history. And I said by the time I was through with that, I often knew what the problem was. There could be more than one problem. They could have a combination of the schedule like that, say too long in bed, and the habit, but they might then be in a situation where they're rocking and rubbing the back for 2 hours from 7 to 9, trying to get the youngster to sleep, thinking that there's a problem when they're simply trying to get the child to go to sleep at the wrong time. There were all kinds of variations of that. They could fall asleep quickly and wake up at 7 to 7, but then there'd be an hour or two in the middle of the night where they'd be wide awake. So that's before we really understood first sleep and second sleep is how we used to sleep historically, with a longer time in bed and an open period in the middle of the night. They didn't know what was going on and assumed something was right. And I would just add up the hours of sleep on both sides and make bedtime and waking that far apart, and it would close up very, very quickly. I started writing that book not that long after we started the clinic, although it didn't come out for a few years after that. And I didn't know if that would work well or not, but the motivation from that actually came from my brother-in-law, who was a business person and ran companies. That's what he did. And at one point early on, he had been, I think, the CEO of Ace Publishing, so a small paperback book firm. I think it was out of Puerto Rico. But he still knew a lot of people in the industry. And he was always trying to look to see what could be done. And he asked me, did you ever think of writing a book? And I said, no. And he said, well, I mean, do you think that'd be a good idea? And I said, I think it would be. And he went around and pitched it. And Simon & Schuster liked the idea and signed me up to do that. And took some years to finally get the final thing out, but that's what got me started. One of my goals in writing that, and particularly in the second edition, was I wanted to write it in a way that was speaking to people, not just a list of things, but I knew how I talked to people. I often gave examples of how different things were done and what worked, other things to help them understand. Habits, I gave other examples of habits that everybody has that might be feel hard to change, or so they could really understand that. And I also wanted to write it in a way that a practitioner who was seeing children could read it and have a feeling of how to talk to children, how to take the history. And to get that to my satisfaction, that's what took a long time. There were a few things in the first edition in particular that I was unhappy with, based probably on the fact that I had, when I started writing it, not that much experience. But by the time I did the second edition, I'd seen, thousands of families, and I could take out the things that didn't belong there, put in the things I felt did belong there. I did get, when it came out, I had the advantage of, back then, it was basically the only book on the shelf if you went to look on helping your child's sleep problems. So I didn't have any competition. But somebody from the program 2020 got interested because he had a child, and he contacted me and he said, could we do a show on that? And I wouldn't say no, but it was, who knew what was going to happen? This is, again, things that are fortuitous. So we set up the next family. The next family, after we agreed to do this, came in with a young child, about one. And I said, could we, and we listened to us, could we do that, have them do this as a video for television? And they said, okay. And so we did it. It was somebody with basically habits. I think she was being rocked. And they had to put her down, and they showed the family starting to go, and the mother says, no, wait, and they would go, and you'd have pictures of the child kind of standing and crying and then figuring out how to settle themselves. And they told me they could only stay 3 nights. If things weren't better, by the 3rd night, they were just going to have to report on what happened. So on the 3rd night, they went in, put the child down. The child fussed for about a minute and went right to sleep. And all the pictures were of the cameramen sleeping on the sofa because they had nothing to take pictures of. So that was shown, and I got a lot of publicity from that, which really helped our center grow, and things went really very well from that point. Well, in terms of my recollections from the beginning, I'm not sure I can remember all the nitty gritty, but I will say a couple things that I felt were important. Number one, for me, when I started our center in 1978, or we started it, there were no other ones for people to think of or even recognize as necessity. So I didn't get much support within the hospital, and I didn't get many referrals from within the hospital. The referrals came, like I said, somebody would call up, switchboard, come to us, go back, and then go to their pediatrician. And he'd ask them, are things still bad? And they said, no, we went into children's and they fixed it in a couple of days. And when he'd hear that from two people, he would say, and then the next person would come in, he'd say, I don't know, but we've had a couple of good luck with this, and they would go in. We built up the referral base outside. But still on the inside, if people would see me in the hall, people, I knew forever, but it was always the same. It was, hi, how are you sleeping? And then they'd laugh. And just the idea that it was kind of silly. And I go through the year and my ego around this would be kind of dropping. Is this really worth it? Am I doing the right thing? That's where the early meetings would come in. I would come and hear this group of people, like some of the names I mentioned, Dement or Weitzman, Helmet, Chakravarti. They weren't like saying, oh no, that's kid stuff, now we're into the real stuff. They were saying, this is terrific, this is interesting, this needs to be done, that's great, tell us more, do this, do this. And I would just get so pumped up and feel so energized, because these were people I really thought were smart people. And as an aside, I think I started to say this, right or wrong, I felt this was a group of people, all of whom, there was like Catesby Ware, but they were psychology background, so there were more than now. But everybody had a pathway that could have been followed to success. Do this, do a residency, do this, and then eventually I can retire. But the folks that went into sleep went up and at some point turned a corner. And they went into an uncharted area that they felt they were going into because it was interesting and important. Rofwarg was another early person. And I felt that pulled off a group of special people who were very smart, very interesting, very willing to not just go ordinary pathway. And so I respected these people tremendously. And the fact that I could go to these meetings and get pumped up really is what I felt kept me going from the beginning. The early meetings were just about how do we form a society? What do we want? Is it a group of people? Is it a group of centers? One of the early things that came up was we need a nosology, and Howie Rofwarg took that on himself to really handle most of that first nosology that we had, which was very important to make it a field. That then it was okay, if we're a field and we have specialists and they're doing sleep studies, how do we have any control over what they're doing? We're going to have to set up an exam committee. And Helmut took that on. And what do we put in the exam? What's even right? Back when you're not really sure actually what was right. I mean, and sleep apnea then, when it started, sleep apnea was not the driving force to the laboratories. The idea was the sleep studies was going to explain, like insomnia, the discovery that everybody knew about sleep apnea, but nobody had any idea that it was so common. And then that, of course, became more and more common. And then there were the issues of how do you score that? What's abnormal? What's not abnormal? And then this was before CPAP, and then who gets a tracheostomy, and then eventually CPAP just changed all of that. But there were these great discussions about what do we do? We're starting a field. Eventually, it was decided to add the name medicine to it because they felt that it was going to be more important to make all the points they want to make as a medical, viewing sleep as a medical issue and not as they're afraid that too much might be viewed as psychology. That's why they eventually added the term medicine to the Academy's name. And I can't remember this year by year, iteration by iteration, but it was very, very interesting in terms of taking a look at this to make a field. How do you go in and make a field? And of course, Bill Dement was the driving force always back then. But they made really good decisions. What we need is a nosology, as an exam. We need committees. We need to bring more people in, eventually fellowships, and so on to where the field is today. But it all came out of those early sessions with some really great folks who were taking the long view and felt that they were in something very, very important. The AASM is an association of sleep professionals and clinic and laboratories dedicated to diagnosing, treating sleep problems, and improving treatment and recognition of all these issues, as well as spreading the importance of it, teaching it to it become part of regular medical thought, and also pressuring Congress and to get appropriate laws passed to support this, get the national center set up. This was really driven from the Academy. I mean, originally, the Academy, or the precursor, was very tiny, and there was the big APSS, what was called APSS back then, but that was all research. And gradually the clinical part grew, and then we had the part about these two parts of it. Could they work together? And then eventually we were able to get together. There were some tough times between the early SRS and the early Academy and who was in charge. But eventually these were ironed out so it could all be under one rubric. So they would have all of these aspects. That's a long answer to a question of what does the Academy mean to me. But it started off as one thing, and it's grown and grown to encompass all aspects of a field, which has just been, I think, tremendous. Well, I'll just tell you a couple things. When we started our center in 1978, we were basically the only center in Boston. There weren't adult centers yet. I think they were doing a few studies at Boston University, but there basically weren't. So if an adult needed a sleep study, they came into our laboratory. So we could do a baby one night and a 90-year-old the next night. And I felt like I had a unprecedented view of life, of sleep across the life cycle. we would do all ages. And this went on for some years. Gradually, our hospital got more and more uncomfortable with it as a pediatric hospital. And then eventually the Beth Israel opened their center initially with Mike Biber. And we detached from doing adults. But during those years, I really could see sleep at any age, the entire spectrum. And I really felt I gained an understanding, certainly polygraphically, that I wouldn't have gotten any other way. Another thing had to do with teaching, that I felt I was having success, I felt I was getting good, that I knew how to take history, I knew how to listen, I knew how to size things up, sometimes just by watching. That I would try to get both parents to come in together, if at all possible, to give me the history. That I could see if only one person was talking. I could see if the parents were sitting facing away from each other the entire time. I could see if, I would say, how many times does the child wake up at night? And the mother would say 8 and the father would say once simultaneously, and then they would kind of look at each other and she might say, well, how do you know? You sleep through it. You really get a sense of the dynamic of what's happening. All of that I felt was important when you designed an intervention. You had to understand that part of it as well. And when I first started the program, I had taken a position at Children's as the sort of the pediatrician for our psychosomatic unit. These were youngsters where they had either psychological problems that led to medical issues or the other way around. We could have anorexics there, we could have fire starters, we could have diabetics who kept showing up in coma and so on. But I got very much better, I should say, of taking a history, asking questions that were otherwise kind of invasive questions and feel comfortable about it. And I was able to bring that over to the sleep program, and I felt more comfortable asking about that, asking about marital issues, and also sensing it. And one of the questions I had was, could I teach this? Was this just something I could kind of learn myself? But when somebody else comes in, how can I teach that? And I wasn't sure, and that had a lot to do with what's going to happen to the clinic. Will it be able to survive? Will other ones be able to open? And I found that the same way I learned by so many people medically was watching them, listening to them, that I could have and just like I learned from Elliot Weitzman, I could have them come in and just sit while I took the history, and then afterwards we could discuss, did you see this? Did you see that? Do you know why I did that? And then eventually they would take the history, and then I might come in and finish up because I could see that there were some points left. But I found it could be taught, which was good and bad. I wasn't the only one in the world who could do this. I could live with that. But it was wonderful to know that I could teach it, and that this clinic then could grow and it could spread. And it started to, I don't know, maybe 10 years later, it started to pop up. Other places started to have it. And I think pediatrics kind of followed a similar curve as adult sleep just about 10 years later. But I was very, very happy to see that could be done. And I was very happy to see that the other centers, certainly the ones within the society, all had the same basic approach. They didn't have some crazy idea or it's all this or some miracle vitamin or something. They all were scientifically based and paying attention and doing it the same way. So I was very, very gratified.